Well, good afternoon, everyone. My name is Tess Taylor, and I'm a specialist in the Community Education Department at MDA. We're thrilled to have you join us today for our webinar, Cardiac Care for Neuromuscular Disease. This learning event is part of our larger MDA Community Education program, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the Community Education section on mda.org for updates on upcoming events. We are recording today's event and we'll be posting it to the website for on-demand viewing at a later date. Everyone registered for today's session will receive that information in their inbox. Please know that all phone lines have been muted, but you can still ask questions. We have a Q&A session at the end with Dr. Hickey today. If you are logged in live, you can use the chat feature or the Q&A feature to type in your questions. MDA would like to thank our program sponsors, Edgewise Therapeutics, Mitsubishi Tanabe Pharma America, and Regeneron Pharmaceuticals for partnering with us on today's webinar. For 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers its mission through research, access to care, advocacy, education, recreation, and engagement. Since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. Our MDA care centers are located at over 150 top medical institutions nationwide, providing care from clinicians who specialize in neuromuscular disease. MDA's advocacy work focuses on support for accelerated approvals and novel research, access to healthcare, accessible air travel, and more. This focus plays a vital role in shaping laws and policies that support the needs of people living with rare neuromuscular diseases. Our community education and recreation programs are designed to connect individuals and families. We are committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. Every year, we offer over 40 educational programs, over 20 summer camps, and dozens of other community activities, both in person and virtually. If you haven't done so already, we invite you to join the MDA community by registering with us. Registration is free. Please see the link in the chat. To learn more about MDA, please visit mda.org. Now it is my pleasure to introduce our speaker today, Gavin Hickey, MD. Gavin W. Hickey, MD, is an advanced heart failure, transplant, and pulmonary hypertension cardiologist and is certified in cardiovascular disease, advanced heart failure, transplant, and echocardiography by the ABIM and ASE. He is Medical Director of the Ventricular Assist Device Program, Program Director of the Advanced Heart Failure, Transplant, and Pulmonary Hypertension Fellowship, Chair of the Cardiogenic Shock Committee, and is an Assistant Professor of Medicine at the University of Pittsburgh School of Medicine. He received his medical degree from the University of Rochester School of Medicine and Dentistry and completed his residency at the University of Pittsburgh Internal Medicine Education Program, followed by his Cardiology and Advanced Heart Failure, Transplant, and Pulmonary Hypertension Fellowship at UPMC Presbyterian Hospital. His clinical and research interests include heart failure, heart transplantation, mechanical circulatory support, including ventricular assist devices, and cardiogenic shock. Dr. Hickey has numerous publications and has presented at national meetings for heart failure. He is a member of the American College of Cardiology, Heart Failure Society of America, and International Society of Heart and Lung Transplant. He lives in Murraysville, Pennsylvania with his wife and 3 children, where he enjoys playing and coaching soccer. And thank you so much for being here today, Dr. Hickey. We're so excited for your presentation. I will stop sharing my screen so I can turn the time over to you.
Thanks for the introduction. Really appreciate that. And of course, a much younger picture of me, which is always appreciated. I will start sharing my slides here. I just want to make sure everyone can see those. Are you able to see those?
Yes, we're able to see them. Thank you.
Okay, perfect. Okay, so we'll talk about cardiac care in neuromuscular diseases. And this is by no means a comprehensive lecture. This is meant to kind of have a broad overview of generalized cardiac care, spanning a lot of different neuromuscular diseases. And of course, I want to make sure there's time for people to ask some questions. So thank you again for having me. I don't have any financial disclosures, and I want to note that a lot of these slides were developed in conjunction with other what I would call experts in the field, and I've named them here. So I had a lot of help getting some of these slides together. Objectives today are to understand the relationship between neuromuscular disease and cardiac health, explore some of the strategies for monitoring and managing cardiac health in individuals with neuromuscular conditions, and also talk about current and emerging therapies for cardiac care in the context of neuromuscular diseases. So from a cardiac standpoint, what do we need to think about in this patient population? So cardiac surveillance is one of the most important things. And with surveillance, I'll walk through some of the key monitoring and imaging tools that we use. I would like to focus, of course, on the fact that many patients never really require any advanced interventions, but there is a high variability in the severity of disease. Dilated cardiomyopathies or reduced ejection fraction, which is the strength of the heart and how much the heart pumps, is sometimes the first thing that we see even before symptoms in patients with neuromuscular disease. And that is not directly related all the time to the degree of weakness. Cardiac fibrosis or scarring is something that we do keep an eye on, and you'll see why it's important to note those things. Arrhythmias in certain types of neuromuscular diseases especially can be very important to diagnose early, monitor and treat. And then, like I said, we'll talk about testing and overall care. So I'm going to go through 3 cases as just kind of a background to have in your minds as we walk through these this presentation. So, excuse me, case presentation number 1, 32-year-old man with progressive muscular weakness starting at age 21, and a cardiac MRI that showed reduced heart function, ejection fraction 20%, and normal would be 55 to 60%, and presence of fibrosis or scar tissue in the heart. The heart function with good medications improved to 30 to 35%, and an ICD or defibrillator was implanted, and this patient was using a motorized wheelchair by age 32. So in this case, the amount of weakness from skeletal muscle and the amount of cardiac degree of weakness was pretty similar or pretty equal. In case number 2, this is a case of Becker's muscular dystrophy, a 28-year-old man with mild to moderate proximal muscle weakness, able to work in a packaging facility with no evidence of any cardiac involvement and no scarring. So obviously has some skeletal muscle involvement, but no cardiac involvement. And then we have another case of a 52-year-old man who worked in home remodeling, exercised at the gym twice a week, but at age 40 was diagnosed with some cardiac issues, including atrial fibrillation, which is an irregular rhythm from the top chambers of the heart, and cardiomyopathy, or a weakened heart. And that patient received a heart transplant at age 49. So in this case, the patient had no muscle weakness, but required a heart transplant due to cardiac weakness. So had a lot of cardiac involvement, but not as much skeletal muscle involvement. So the points here being that muscular weakness is not necessarily associated directly with cardiac involvement. And so, I have Becker's here as a kind of a background neuromuscular disease that we see often. And in these cases, what we see is that sometimes the skeletal muscle involvement, cardiac involvement can be equal. Sometimes we have more skeletal muscle weakness than cardiac weakness. And sometimes we have a lot of cardiac weakness without other weakness. And again, I'm using Becker's as an example here, but this can occur in a lot of different types of neuromuscular diseases. So there's really no direct correlation of cardiac involvement with skeletal muscle involvement in neuromuscular diseases. But cardiac surveillance, or how we detect cardiac disease and neuromuscular disorders, is really important. So how do we surveil for cardiac disease? So symptoms are really important. what are the symptoms that we're looking for from a cardiac standpoint? Shortness of breath, although that can occur for a lot of different reasons, right? So that can occur for pulmonary reasons as well, and muscular weakness in the diaphragm. Palpitations can occur as a first symptom in many types of neuromuscular disorders, including myotonic dystrophy, where arrhythmias and atrial arrhythmias are very common. Palpitations are not always necessarily a bad omen. Many people who do not have neuromuscular disease and do not have cardiac involvement have palpitations, and we oftentimes will do some testing to determine the degree of those palpitations, where they're coming from and how severe they are, and I'll get to that in just a moment. Fluid buildup. So if fluid is occurring, that can happen for a lot of different reasons, but certainly we would want to rule out that it's coming from the heart. So fluid can build up with low protein or dependent. Being upright, gravity will take fluid down toward the lower extremities. But fluid buildup in the lungs is always a concerning feature and always concerning for potential cardiac involvement. Fatigue or more tiredness than usual or lethargy can be a first sign. And chest pain or discomfort, again, isn't specific to cardiac disease, but certainly could be a sign that there is cardiac involvement. So if palpitations are present, and sometimes even if palpitations are not present, if there's a high risk for cardiac arrhythmias, we will do cardiac monitoring. Typically, this is done once per year if someone is asymptomatic but at risk. If someone is more symptomatic, we may do that more frequently. If someone is asymptomatic and not at risk, we may not do any cardiac monitoring at all. Short-term cardiac monitors for either a day or up to 3 days. The Holter monitor can work for that. We now have these Zeo patches that we can put on. Those patches can be 3 days or up to as many as 10 days or 2 weeks. Longer term monitoring for patients who are having maybe infrequent episodes of palpitations. An event monitor recorder, a 30-day event monitor can be available. And sometimes we even do these loop recordings where you can actually implant a loop recorder under the skin. Of course, now sometimes people even have Apple Watches or other types of monitoring devices that you can wear. They call them wearable devices, and they can download to the phone. And if you're wearing those and it comes up as something is abnormal with the heart, of course, you can download that and send it to your doctor. So now we're in this age of technology in which we can pick these things up even faster. And we're really lucky to have a lot of cardiac imaging tools. So an echocardiogram is an ultrasound of the heart. And what it does, it converts sound waves from your heart into pictures of the chambers of the heart. So we're able to see the top chambers of the heart, which are the filling chambers, and then the ventricles, or the bottom chambers of the heart, which are the pumping chambers of the heart. And we're also able to look at the valves to make sure that all the valves are intact. We can look at the ejection fraction, so it said the squeeze of the heart of both the left and right side. And we can look at pressures in the heart as well. So the echocardiogram is a nice screening tool to give us a lot of information about what's happening in the heart. Another imaging tool we use is a cardiac CT scan. This is a nice non-invasive way of looking at structures around the heart. It can tell us about things like ejection fraction. Some patients who have difficulty using an ultrasound to look at the heart, that's about probably 15 to 20% of people. The cardiac CT scan is usually a little bit better at us being able to look at those images, so it can tell us about the heart and also the vessels that go around the heart. And then the cardiac MRI, which is actually probably our most detailed imaging tool, is an MRI of the heart that can tell us about all of the structure, all of the valves, the pumping function, the pressures, and the flow of the heart. So it's the most comprehensive. However, again, some patients are not able to tolerate cardiac MRIs because the tube is pretty small, and so claustrophobia or even contractures can make it very difficult to do a cardiac MRI. So we have to make sure we're choosing the right imaging tool for the right patient. So again, just getting into the echocardiogram a little bit further. So again, what do we see on an echocardiogram? So we want to see the squeeze of the heart. We want to see how well the heart is pumping. And we want to know that about the left side of the heart, which pumps blood out to the body. We also want to know that about the right side of the heart, which pumps blood through the lungs. We want to look at the overall size of the heart. So a normal heart is about 5 centimeters. If we start seeing that heart getting stretched out further, that could be a sign that maybe we need to start intervening and using medications, or maybe your heart is working a lot harder than it needs to. And then we want to look at the valves of the heart. So you have 4 main valves of the heart: the pulmonary valve, the aortic valve, the tricuspid valve, and the mitral valve. Basically, any one of those can either develop stiffness or leakiness. And what we need to see in the echocardiogram is if any of that is occurring. We'll also to see if there's any fluid buildup around the heart, or if the pressures in the heart are high or low. We'll also be able to tell in some cases if there's any blood clot buildup in the heart. That's pretty rare, but it can happen. We also look at the aorta, which is the major blood vessel that comes out of the left ventricle and gives blood to the rest of the body. So during this procedure, what is expected of the patient? Basically, you're going to lay down on your side, and the echo tech is usually going to use the ultrasound probe and push it up against the chest to see these pictures in the heart. And we also attach it to an EKG. So you get these kind of sticky pads on. We use a gel to allow the probe to actually see and the sound waves to conduct. And then what we do is record those images. So, and the tech won't often tell you exactly what they're seeing. They just make sure they record it. And then there's a doctor who reads that echocardiogram in a separate room. And that's when we get the reports back. Okay, a cardiac CT scan. These are becoming more popular. You may hear more about these. Basically, it's a CT scan that looks at the heart and blood vessels. Sometimes we use CT scans to look at things like the lungs, or to look for infections, or to look in the abdomen for any signs of organ dysfunction there. But in this case, we're talking about the heart and the blood vessels that go around it. So the CT scan is a good way to look at the coronary arteries, to make sure there's no blockages there, instead of doing the alternative test, which is a left heart catheterization with the coronary angiogram, which requires us to actually go into the artery, go up to the heart, inject dye, and take an X-ray. So this is much less invasive. It will tell us about all the heart chambers, muscles, and valves. It will tell us about the structures around the heart, including the aorta and also the pulmonary veins. And it also tells us about the sac around the heart. And then the cardiac MRI. So again, this is the most detailed pictures that we'll get of your heart. We would recommend it to, if we're not sure exactly what the ejection fraction is, the cardiac MRI is the gold standard for determining the ejection fraction or pumping of the heart. It also will tell us if there's any fibrosis or scarring in the heart. So the MRI is the only one that gives us the detailed information about whether there's any scar tissue built up in the heart. It will tell us about flow through the heart. It tells us about heart valves, structures around the heart, even structures in the lungs and in the abdomen sometimes. So how does a cardiac MRI work? You'll lay flat on the table. You slide into a long tube. You'll be asked to kind of breathe in and out. You get contrast or dye that will help us see the heart better. Sometimes we do ask to hold breath and things like that. So, you know, from a breathing standpoint, claustrophobia standpoint, just geometry standpoint, it can be a little bit of a challenge to get a cardiac MRI, but it also gives us the best pictures. Okay, so here's kind of the overall assessment of the cardiac imaging tools. So echocardiogram takes about 30 minutes, not very expensive. It's non-invasive. The quality of the echo depends on our ability to actually see the heart from outside the chest wall. The ejection fraction range based on the interreader variability is about 10%. We cannot detect scarring with echo, and there is the potential that we don't get our best pictures. So that's usually our first test, though. Our first go-to is an echocardiogram because they're usually pretty easy to get, and they're non-invasive. Cardiac CT scan would be our next available test, especially if we're thinking about the arteries of the heart. A cardiac CT scan is really helpful for that. It gives excellent windows and quality. Ejection fraction range is smaller, so the reader variability is like 5%. And then it does not detect scar, though, and you do need IV contrast, and you do need a heart rate that's a little bit lower. So sometimes we have to give medications to lower the heart rate. And then cardiac MRI, which is really the test of choice if we're looking into exact ejection fraction, the amount of scarring present in the heart. There is some IV contrast, but typically not as risky as the other contrast for the CT scan as far as allergies or damage to kidneys. So what could we potentially find? We could find that the heart is completely normal, which is great, in which most of my patients, we find that the heart is pretty much normal. Sometimes we find that the heart has either become enlarged or weak or both. And so we call that a dilated cardiomyopathy. What does that mean? Dilated, muscle of the heart, weakness of the heart. And we use terms like heart failure to mean that there's heart weakness. We use reduced ejection fraction to describe if the ejection fraction is less than normal. And again, normal is 55, 60. Anything less than 50%, I get a little bit nervous about the overall pumping function. So dilated cardiomyopathy is a form of heart disease that shows enlargement of the heart and weakness of the heart, and it prevents the blood from pumping efficiently through the body. And this is exactly the type of thing we would want to pick up early so that we can try to intervene early with things like medications. If it progresses, and it progresses to a severe degree where the ejection fraction is, say, under 20%, this is something that can put somebody at in danger of a sudden cardiac death or arrhythmias. So what we want to do, of course, is to catch any weakness in the heart or enlargement of the heart early, and then try to use our medications to reduce any progression. So if we have a dilated cardiomyopathy, the good news is now more than ever, we have really great medications that we can use to prevent that heart from getting weaker. Oftentimes, even if the heart is only showing mild weakness or mild dilation, and this practice varies, but my typical practice is to start these medications earlier rather than later. The medication we use most frequently is called a beta blocker. That medicine can be carvedilol or metoprolol or bisoprolol. It's a medicine that slows the heart down a bit, relaxes the heart a bit. It can lower the blood pressure a little bit. And it is the most protective for survival because it also decreases bad heart rhythms. So beta blocker is an often first-line therapy. For patients who also have diabetes or that have higher blood pressure, an ACE inhibitor or angiotensin receptor blocker, or the combination of angiotensin receptor blocker and antiplatelet inhibitor, or ARNI, is often a good choice. Again, used in combination with beta blocker, these two medications had been for a very long time our kind of standard of care for anybody with a weak or dilated heart. Starting these early potentially has the benefit of reducing the progression or reversing progression of a dilated cardiomyopathy. Other medications we use, aldosterone inhibitors, as spironolactone or eplerenone, excuse me, can be used to control pressure and also fluid levels in the heart. So they're a really helpful tool. And then newer drug pretty much brand new over the past, couple of years. SGLT2 inhibitors, or dapagliflozin or empagliflozin. You probably have seen commercials for those, Farxiga or Jardiance. Those medications help keep excess sugars out of the body. They relax the blood vessels and they get rid of fluid. As far as other therapies, there's really not been any standard role for steroids in dilated cardiomyopathies. If the heart rate remains very high and we cannot increase the other beta blockers anymore, ivabradine is a nice additional medicine, but can be expensive. If the blood pressure is high or there's kidney disease present, sometimes we use a combination of isosorbide and hydralazine. If there is fluid buildup that's coming from the heart, we can use diuretics. Those are water pills. Now, when we look on the echocardiogram, if the pressures in the heart are high and there's fluid buildup, that correlates and says, yeah, that fluid is probably from the heart. We should use water pills. If there's fluid that's not coming from the heart, there's actually a slight danger in using water pills. So if we get rid of fluid, but the heart doesn't have enough fluid to pump, that is where you can get into a little bit of trouble with dehydration. And then less commonly, digoxin, which is a medicine we use for arrhythmia, such as atrial fibrillation. It has to be monitored closely. And then I'm going to talk a little bit about ICDs and heart pumps and transplant. But again, these are things that happen only downstream. So an ICD is something we would use if the ejection fraction drops below 35% and does not return back above 35%, or there's a fair amount of scarring, or the patient is having a lot of ventricular arrhythmias. So I have some information on that in a bit. This slide shows you what we call the 4 pillars of therapy for dilated cardiomyopathies or reduced ejection fraction. And so ARNI, which is an angiotensin receptor blocker plus neprilysin inhibitor, beta blocker, mineralocorticoid receptor antagonist or an aldosterone antagonist, that's spironolactone or eplerenone, and then SGLT2 inhibitors, that would be dapagliflozin or empagliflozin, so Farxiga or Jardiance. And if somebody has an ejection fraction that drops below 50% and we get them on these 4 medical therapies, the overall reduction in risk is 73%. That means for every 4 patients we treat, we can save a life. So using all 4 of these medications in combination is the best way to prevent the heart from getting weaker. I'll also add that avoiding any other things that could potentially weaken the heart, such as, high blood pressure, toxins, alcohol, or methamphetamines or cocaine, anything like that that can weaken the heart, we would, of course, want to avoid doing that. This is a nice graph depicting the relationship between scar in the heart and the function of the heart. And what it shows is that as the amount of scar is present, the ejection fraction can actually drop. So ejection fraction going this way, this way on the screen, the more scar you have, up to 40%, the less ejection fraction, down to 20%. And if you have scar and the ejection fraction drops, then you're at risk for bad heart rhythms to happen. And so this is just a nice picture here showing that the highest risk of people having bad heart rhythms is the patients who have scar and have a low ejection fraction. So what happens if the ejection fraction stays below 35% and or arrhythmias are present? So in this case, we see a defibrillator, and there are different types of defibrillators. There's the transvenous or kind of typical ICD that goes in through the vein, under the skin, in through the vein, down into the right side of the heart. And its job is to detect any bad heart rhythms and then apply a shock if there is a bad heart rhythm. So it doesn't In this case, a single lead transvenous ICD does not give you a benefit of having improved therapy or improved ejection fraction, but it prevents sudden cardiac death. We do have, in some cases, use ICDs that have 3 leads in which they can actually improve the ejection fraction, and those are called resynchronization defibrillators, or CRTs. We also see here a subcutaneous ICD on the right, and what that is an ICD that goes underneath the skin and kind of connects outside the heart. And one of the reasons to do that type of defibrillator is that it reduces the risk of infection. So anytime we're talking about a defibrillator, we have to talk about the risk benefit of the defibrillator. So the risk of putting defibrillator is, it is a procedure, there is a risk of bleeding, there is a risk of infection, there is a risk of inappropriate shock. The benefit is, if someone is at higher risk for having a bad heart rhythm and at risk for sudden death, the defibrillator going off would then prevent the sudden death from happening. So I'm not an electrical doctor of the heart. I specialize in weak hearts, but this is something we would refer to an electrical doctor of the heart to consider into place. So what are the other cardiovascular risk factors, in neuromuscular disease or patients that don't have neuromuscular disease? Hypertension is the biggest risk overall. Obviously, it can be silent, so taking the blood pressure regularly is important. Taking blood pressure medications reduces the risk of things like stroke or having a weakened heart or dilated cardiomyopathy, or something we call heart failure with preserved ejection fraction, which is a very stiff heart. And so we want to make sure blood pressure is treated at a goal. Diabetes. So making sure blood sugars are well controlled is really important for a lot of different reasons. But if the sugars are high, that could put you at risk for things like infection, vascular disease, affect the kidneys, affect the eyes. And so we want to make sure that we take good care of that as well. Being overweight can be affected with worsening heart outcomes, including sleep apnea. Again, this is something where we work very closely with our pulmonary colleagues into determining whether sleep apnea is present. If it is, it's treatable. Sleep apnea that's untreated can be associated with high blood pressure, daytime fatigue, and somnolence, and also can affect the heart by increasing the pressures in the lungs. Smoking is obviously something we would say puts somebody at very high risk of cardiac disease by creating calcium in the arteries, and of course lung disease, which can increase pressures in the lungs and on the right side of the heart. Cholesterol is also very important and very treatable. So we want to make sure that the cholesterol profile is monitored. We can use statins, but honestly, in the neuromuscular disease population, we try to so we don't want to exacerbate any myopathy or muscular pain. But perhaps newer medications, these PCSK9 inhibitors, might be better options for the neuromuscular disease population. It's possible they may be also more costly, depending on your coverage. Okay, so it is very, very rare, and I want to make sure I emphasize, it is very, very rare that we have to use left ventricular assist devices, that the heart gets to that point is that weak, and as a major cause of quality of life, worsening quality of life. But we should know that they are available and that they are very safe. So what is a left ventricular assist device? It's a heart pump, mechanical heart pump that sits inside the heart and through an outflow graft pumps blood out to the aorta, which gives blood to the rest of the body. So this is a picture of what the heart pump looks like and the outflow graft. And then in order for the pump to work, unfortunately, we don't have any pumps that run by themselves inside the body. So it connects to a brain or battery, this controller, So this comes through the abdomen, connects to a controller, and that controller connects to 2 batteries that patients carry, typically in a vest of some sort. The outcomes with the newest LVAD are phenomenal. We know that patients who have very weak hearts that would require a heart pump, their overall 1-year survival is less than 50%. With these pumps in place, the 1-year survival is closer to 86% and 5-year survival up to 64%. For younger patients, the survival is even better. And so what we worry about and why we don't just put pumps in before they're needed is a risk of things that can occur when you put a mechanical pump inside of a human body, which is that you can develop infection, you can develop clot. Because you can develop clot, you can develop stroke. And because you can develop clot, we need blood thinners, which can put people at risk for bleeding. So these risks are present with these pumps, but as you can see, the overall risks have actually decreased substantially. So stroke, 1-year risk of stroke is 93, is free of stroke, 93%. So less than 7% of patients have a stroke in the first year. And at 5 years, only 13%. So if it happens early, typically, not later on. GI bleeding is something that can occur. Again, about 14% of patients get that in the first year. Blood clot in the pump is very, very rare, less than about 2% at 2 years, actually. And then device infection, which is common but typically treatable if caught early. And so that risk, again, is about 14% the first year. And up to about 50% of patients have it past 5 years, but again, is oftentimes treatable. And then transplant, again, it is very rare that the quality of life in our neuromuscular disease population is limited by the weak heart itself. And so in those cases, we do sometimes do heart transplants, but rarely. And once a heart is placed, of course, there's a risk of things like antibodies and rejection. And so we have to make sure that everyone is on really good medications to reduce the risk of rejection. And that allows that heart to be inside the body for a long period of time. Most recently, median survival is upwards of 12 to 15 years after a heart transplant. And the patients who do the best are the ones kind of in that middle range of somewhere between 30 and 50 years. So the downside of heart transplants, of course, is that we can't yet grow hearts on trees. So we're kind of stuck with what's available. And we only do about 3,500 heart transplants a year in the US. So it's, maybe up to 4,000. So if even, 10,000 people need heart transplants, it's probably more than that. We run the risk of not having enough. So this is something that is highly scrutinized and also something we don't take lightly. But again, in neuromuscular disease, it's pretty rare to require a heart transplant. I will just say that I defer a lot of the pulmonary discussions to the pulmonary specialists. It is really important to also work closely with the pulmonary team. I'm very lucky at UPMC. I have a great pulmonary team that we work with, but we do serial pulmonary function tests. If there are surgical procedures, it's really important to have communication between your team and anesthesia about what are the considerations we need for the procedure. And then, of course, any positive pressure ventilation and things like that during sedation or intubation. So I rely very heavily on my pulmonary colleagues when it comes to these things. Okay, so key takeaways here, and we should have about 20 minutes here to go through questions. Surveillance is very important. Typically, if I think someone is at risk for palpitations or dilated cardiomyopathy, I will do a Holter monitor or Zio patch once per year and an echocardiogram or MRI once per year. If the ejection fraction even gets close to 50%, I think being very aggressive about guideline-directed medical therapy as much as tolerated to reduce progression of the weakness of the heart or even improve the function of the heart is really important. So guideline-directed medical therapy with your ARNI, your beta blocker, your MRA, and your SGLT2 inhibitor. If the ejection fraction is persistently less than 35%, or there's scarring or ventricular arrhythmia present with that, it is very reasonable to put in a defibrillator in order to prevent a sudden cardiac death. There are some risks with that, including infection, bleeding, and inappropriate shocks. And that risk benefit needs to be a formal conversation with your doc, your family, and the electrical doctor. And if there's an arrhythmia present, oftentimes I rely on my EP or electrophysiology, cardiology consults. Luckily, again, I have a great team here. Sometimes if the heart rhythm is coming from one area of the heart, we can go in, can burn that area out. If it's something that's happening from multiple areas of the heart or because the heart is weak, we may use medications, or sometimes, like I mentioned, do advanced therapies like VADs or transplant. And if the heart remains weak despite everything that we can possibly think of to make it better, then sometimes we think about VAD or transplant, depending on overall quality of life, of course. So that is all I have. I will stop sharing and open up for the chat questions.
Thank you so much, Dr. Hickey, for your presentation. Let me just switch back over to share my screen, and then and we can get started on those questions. All right, so we did have quite a few questions in the chat. Some were more general and some were case specific. Do you mind taking case specific questions, or would you prefer to stick to general questions?
I'm happy to do some case specifics. Maybe do the generals first. If we have some time, I'll try to hit some of the more specific ones.
Sounds great, thank you. So we had one question in the chat. Can you take the CT scan or MRI scan instead of the nuclear stress test?
Yeah, absolutely. It is dependent on things like the renal function, to make sure the kidneys are good enough for the contrast. Also, just body positioning is really important. Of course, claustrophobia for the MRI, and then because a nuclear stress test may be appropriate for some patients, but if there is other considerations such as body habitus, so if there's a lot of upper extremity density, the stress test may not be the best. Nuclear stress test may not be the best. The cardiac MRI may be better because it goes, actually looks inside the body. So it kind of gets rid of all the excess artifact that can be seen. So I do recommend it generally for women. I generally tend to send a cardiac MRI a little bit more just to avoid any artifact. As far as like nuclear stress tests in general, I think if the overall risk is relatively low or there's been a heart cath in the past, I think nuclear stress test is very good at ruling out any major things. So I think in that case, it can be very useful. If you're really looking in depth, or it's like a first time you're getting detailed imaging, a cardiac MRI is great.
Great, thank you. So another question from the chat, at what EF do you recommend an LVAD?
So an LVAD is only indicated if the ejection fraction is less than 25%, and the filling pressures on the left side of the heart are high. So if the ejection fraction is more than 25%, we won't even qualify for an LVAD because it won't be, from an insurance standpoint, it will not be reimbursed. So we actually can't do them. And I would argue that really, because you have this mechanical pump that's very powerful, it actually could put you at higher risk for bad things. So if the ejection fraction greater than 25%, we will not do that. That was a good question.
Great, thank you. So my cardiologist does not know much about my neuromuscular disease. How do I receive proper care? And do you know of any resources for my cardiologist?
I think the most important thing is that if you can get at least one time per year to a center where they have some experience, I think that's probably the most important thing. And it does depend a little bit on the severity of the neuromuscular disorder, the type. So for example, if you're talking about something like myotonic dystrophy, where the main risk is really just arrhythmia, most cardiologists can manage that, right? If it's just a atrial arrhythmia or supraventricular tachycardia or something, like most cardiologists can manage that. I think when it becomes harder is in patients with Duchenne's or Becker's or other more challenging ones. That in those cases, it is helpful to have a whole team, and actually having a lung specialist that can work on the AVAPs and positive pressure ventilation, and a neuromuscular specialist that can work on what types of physical therapy should be doing, or there other trials out there, and then a cardiologist who has some degree of heart failure training, I think, is probably important. Most academic centers, so most universities, have people who have that experience, and you may just have to ask a couple of times to find that person who's able. As far as cardiologists who how they can gain insight, I think that at many of the kind of national conferences, there are resources available. I'll be honest, this is kind of I would say it's kind of a blank space to a degree in research from a heart standpoint as to exact management. So I was trained by somebody who was specialized in heart failure, who did work in muscular dystrophy, and so it's been passed down a little bit. It's not like there's a lot of guidelines out there for treating muscular dystrophy, and part of that too is because there's such heterogeneity in the patient population that really isn't one size fits all, right? I also think that things have changed. 20 years ago, the practice wouldn't have been ejection fractions 50%, let's start them on a beta blocker and a other medication, an ARB. But now we know that even patients where the ejection fraction is 40-50% probably benefit. And so an earlier, more aggressive therapeutic approach, although not studied, is probably what's right for the patient. And so I don't have firm evidence for that, and I don't have guidelines for that, but it seems like in practice to make sense. And most patients tolerate those medications very well.
Great, thank you. That was very good feedback. So as a relatively young person with Becker's, at what age should I start paying attention to my heart health more and/or start taking heart medication?
I would recommend at least yearly echocardiograms. So, and if the ejection fraction goes below 50%, or if there's other signs like shortness of breath, fatigue, fluid buildup, at that point, I would recommend that someone gets started on medications and has a little closer follow-up. Even then, I still generally, because the progression tends to be pretty slow, even yearly echocardiograms to assess progression, enlargement of the heart, ejection fraction, most of that can be done with echocardiograms. If the ejection fraction falls closer to that 35% range, that's when I really start thinking about cardiac MRI. If someone has other risk factors for coronary disease, so heart blockages run in the family, we've had bypass surgery in the family members, smoking or high cholesterol, high blood pressure, I might want to at least one time rule out any blockages in the arteries of the heart. So a coronary CT scan or even a heart catheterization might be indicated in that case.
Great, thank you. On a similar question, a person who has LGMD2N, they don't have any breathing or heart issues, but do you still think they should see a cardiologist?
I think it is reasonable to check in with a cardiologist, have at least a baseline EKG and maybe a baseline echocardiogram. And if those are normal, it may only require up to every 3 to 5 years seeing a cardiologist. But if they're abnormal, I think then it would probably be a yearly follow-up. So I think that it's always helpful to have a cardiologist that at least knows you, maybe knows a little bit about the disease, even if they're just looking it up. I think that's always helpful. So I would say at least one EKG and possibly an echocardiogram as just a baseline is reasonable.
Absolutely, thanks.
Yeah, and that can even be ordered by a primary care doctor. It doesn't have to be a cardiologist. So, and if those are completely normal, then maybe even stave off the cardiologist.
That's great. That's good advice, to go through a GP first. So we had a question about a recent clinical trial. Do you happen to know the status of the Reichels phase 2A trial for CPVT?
I would have to say I do not.
That's
fine. Sorry. I try to stay pretty caught up on most of this stuff, but that sounds pretty specific. If anyone wants to enter any specific questions or comments about that, I'm happy to take a look. But I'm not aware of that data.
No problem, thanks. So I have generalized myasthenia gravis and have lost approximately 50% of my muscle mass over the last 9 years. Have you ever seen cardiac involvement with a myasthenia gravis diagnosis?
It's rare, it can happen. Whether it's directly from the myasthenia gravis or just related to other things that can happen to people as they get older, I'm not sure. Again, what you're looking for things like shortness of breath or fluid buildup or palpitations or racing heart. I would say those would be things that would make me think about getting, an ultrasound or echocardiogram. But it isn't, I wouldn't say it's high enough priority that you would just do one as a screening. Wouldn't be like my first thought process, at least.
Yeah, absolutely. Thanks. So now we have a few more quite specific cases. So this one person, I have developed chronic respiratory failure. Last June, an X-ray found that I have a right elevated hemidiaphragm. The pulmonologist put me on Respimat, Combivent, Smart Vest, and a cough assist. Lately, I've been having chest pain off and on. Can respiratory failure affect the heart in time? This is another person who has LGMD too. They also suffer from bronchitis and some other conditions.
Yeah, so what we worry about kind of long term for anyone who has lung disease, and that could be anything, COPD, sleep apnea, ILD or scarring, elevated hemidiaphragm. What we could look for on echocardiogram is look at the right side of the heart and the pressures in the lungs. And so as long as the pressures in the lungs stay pretty normal, the right side of the heart will work just fine. And so rarely do we have a problem. If the pressures in the lungs build up, so say somebody gets a bad pneumonia or a pulmonary embolus or blood clot in the lung, over time that pressure can really build up on the right side of the heart, and the right side of the heart just isn't used to pumping against high pressures. And so what could happen over a longer period of time is that heart isn't able to keep up and then fails. That's a very difficult thing to treat if it does happen. It doesn't typically happen fast. It typically happens over a longer period of time. We do have usually some interventions that we can do to try to keep those pressures in the lungs down and allow the right heart to pump better. But the main risk would be that the right side of the heart over a long period of time maybe doesn't work as well. Signs of that are that you can get congestion of the kidneys and liver, and fluid can build up in the belly or in the legs. So that's something we would keep an eye on. But even just a screening echocardiogram every 1, 3, or 5 years, depending on the pressures in the lungs, would probably be able to detect that.
Great, thank you. Thank you. That was very thorough. A few others, and then I think we'll wrap up. So how much should I rely on Optival? I'm functionally quad, severe Becker's, and pacemaker dependent. EF on fringe of normal, biventricular pacemaker suggested, but no space in vessel. So what they said, they've survived asystole in field on 100 on Metropol and 25 of Inspira. Use MPV and NIV. What more can I do?
Yeah, so this is a good question, and I can try to generalize this a bit. So when a device is put in, certain devices have certain other features. So defibrillator is one type of device, a pacemaker is another type of device. Every defibrillator has a backup pacemaker. The 3 leads are resynchronization therapy, right? That has the 3 leads that can actually help the heart pump from side to side, so can actually improve function. On those devices, they have something that can measure, to some degree, volume in the heart. So when the question is about Optival, there is a setting on the pacemaker that can pick up this Optival. the hard part is that in order to obtain that information, you actually have to download, and then someone has to look at it and someone has to interpret it. So it's not something that's followed like daily, but if if there were other signs or concerning features, you could look at the last device check and say, oh, this little Optival thing says it's elevated. Should we do something about it? It is not typically practiced that we look at the Optival and say, oh, you need more diuretic, we need less diuretic, right? Excuse me. There are other devices that are much more specific. They're PA pressure monitor devices like CardioMEMS, or Proactive has a device. And what they do is they can sit in the lungs and actually tell you exactly what the pressure is. And it's something you can monitor every day. So you can actually hold a device or lay on a pillow, and actually every single day you can download and show what are the pressures in the lungs doing. And so these devices are things that heart failure doctors use in patients who are a little bit harder to tell. Do you have too much fluid? Do you have too little fluid? So that might be an option for patients that we have trouble trying to figure out exactly what the fluid level is. So instead of Optival, that might be something to consider. If that's not an option, certainly downloading Optival periodically when there's a concern that there's either too much or too little can help, along with some other things like some lab work or other things that could potentially help make a decision about that. It's certainly not easy, but it is nice to have some extra information sometimes.
Absolutely, thank you. So I have one more question for you. And before I ask it, I do just want to let the audience know if we were not able to get to your question that either you put in registration or in the chat later on in the webinar today, please reach out to the MDA Resource Center because we still have resources and ways to answer your questions. So just wanted to put that out there. But this will be our last question for today's webinar. This person says, I am living with LGMD2I/R9 FKRP and have moderate cardiac fibrosis as shown in an MRI. My EF is still strong at 55% and no dilated cardiomyopathy. I have been experiencing dizziness and wondering if this is related to the fibrosis. What is the best course of action to treat cardiac fibrosis?
So there's no specific treatment to reverse any scarring in the heart. But what you want to rule out is any bad heart rhythms causing the lightheadedness or other symptoms. And so the way of doing that would be either to do a short-term monitor, like a Holter monitor or Zeo patch, or if these symptoms are happening infrequently, you would need a longer-term monitor, like a loop recorder, and that could pick up if there's bad rhythms happening because of the scarring. Sometimes people will just be, even though the ejection fraction is normal, start medications that reduce the risk of bad heart rhythms, like beta blockers. So just because there's scarring there doesn't mean you're going to definitely have a bad heart rhythm, and we can't reverse it. But you can do things like a low-dose beta blocker to prevent rhythms, and you can monitor to see if there's any rhythms. And if there are certainly patients who have normal ejection fraction who still require defibrillators if the rhythm occurs as a result of the scar. So I think it's really important to at least yearly, or if those symptoms recur, to get some type of monitoring so that a determination can be made, is that scar causing a problem or is it not? But unfortunately, we don't have anything at this time that reverses the scarring.
Okay, thank you. And thank you so much for all of the answers that you gave to the questions. They were so thorough and supportive, so we do appreciate that. And thank you so much for spending this hour with us today, Dr. Hickey, and answering so many questions and for a wonderful webinar. We do appreciate your time and your support of the MDA community. Thank you.
Yeah, thanks for having me. Appreciate it.
Thank you. MDA would again like to thank our program sponsors, Edgewise Therapeutics, Mitsubishi, Tanabe Pharma America, and Regeneron Pharmaceuticals for partnering with us on today's webinar. This year marks MDA's 75th anniversary. This milestone has been made possible by generations of dedicated support from people living with neuromuscular disease, their families, researchers, clinicians, volunteers, and donors who boldly drive our mission forward. As we look ahead, we remain committed to honoring this legacy, building on the impact we've made together, and continuing our momentum toward transformative progress for people living with neuromuscular disorders. To learn more, visit mda75.org. Last but not least, we again invite you to join the MDA community. Joining is free and will help you stay up to date on our latest programs, as well as the latest research. Please scan the QR code with your smartphone or visit the link in the chat. We would again like to thank Dr. Hickey for sharing his time and expertise with us today. And we want to hear from you. What did you like about today's program? What can we do differently in the future? Please fill out the brief survey that will pop up right after the webinar. Your feedback is important to us and will help us with future programming. And if you have any questions or looking for support or resources, please contact MDA's Resource Center at 1-833-275-6321. That's 1-833-ASK-MDA1. Or you can email us at resourcecenter@mdausa.org. We have live people waiting to chat with you. And if we weren't able to get to your question, please reach out to us there. So that will conclude today's webinar. Thank you so much for joining us, and we'll see you again soon. Bye.